From Diamond Pharmacy Services, this is PodcastRx. On this episode, we're joined once again by Dr. Deborah Milito of Diamond's Long-Term Care Division to discuss recent changes to the CMS State Operations Manual for long-term care facilities. We review a number of revisions and updates related to infection control, immunizations, medication stewardship, and more. It's an easy listening regulatory roundup for any skilled care pharmacist or professional. Welcome to PodcastRx. I'm Adam Campbell. I'd like to welcome back perhaps the second most regular contributor to this show, Dr. Deborah Milito. Of course, Deborah is the Director of Clinical Consultant Services for the Long-Term Care Division here at Diamond, along with being the Chief Antimicrobial Stewardship Officer and the Vaccine and Therapeutics Coordinator. Deborah, how's life treating you today?
Oh, really well, Adam. It's a little bit busy. Last week was nice that it was a holiday and got a couple of days off, but ready to get back into the swing of things.
Yeah, and I would say you're never not busy.
I think I do better with busy.
Yeah, well, that's okay. It's always good to have you here. The last time that we talked wasn't that long ago. It was just back in April or May, and we had a pretty concise discussion around psychotropic stewardship and recent CMS changes related to it. So during that episode, you had made mention that there were some additional medication stewardship issues that we should talk to in a future episode. Well, here we are in the future, and we're here to discuss them. So thanks again for being here. And you actually gave a fairly recent presentation on these changes to your senior care pharmacist colleagues here at Diamond. So I thought basically what we could do is just adapt that presentation to podcast form for anyone who didn't get to see it. Does that sound good?
Sounds perfect.
All right. Well, your presentation, it focused on changes to the State Operations Manual, which took effect in October of 2022. And you focused on updated regulations and FTAGs that impact pharmacy and pharmacists in skilled nursing, and subsequently how pharmacists and pharmacies could help skilled nursing facilities manage these updates. So Dr. Milito, I'll go through each of these FTAGs with you for the discussion and these areas of concern, but before we start, could you please explain to me what exactly an FTAG is? I realize that most of the listeners for this particular episode know what they are, but as someone who does not spend every day in skilled facility care, could you educate me?
So a facility can have a Department of Health come into their facility and do what's called an annual survey, or sometimes they come in and do a focus survey based on a complaint. But if there are found to be any deficiencies, then the facility could in fact get what we call an FTAG. And they go by a different numbering system based on the area in the facility where the deficiency occurred. And most times what the facility will then need to do is what's called a plan of correction or a POC. And usually that satisfies the deficiency. Sometimes if it's a more serious deficiency or FTAG, it could be a monetary penalty, or maybe you can't take admissions for a period of time, things like that.
Okay. It's a way of organizing these areas of compliance and calling attention to them. Now, I'm just curious here, how long do you have to typically get into compliance if you're found to be deficient?
Sure. There are different time frames. They might say that, the facility might say, okay, with this particular deficiency, we can correct it in 30 days or we can correct it in 60 days. Here's how we're going to do it, who's going to be involved. Here's the timeline. So it would depend on the deficiency.
Gotcha. Well, going through your presentation, you've outlined each of these areas under these different FTAG or areas, and we'll start with some revisions to F880, which is infection control. Well, what exactly has changed here and why?
So a couple years ago, actually it was in 2019, November 16th, I believe. No, I'm wrong about that. It was November 28th of 2019. The phase 3 of the CMS mega rule was released and said you have to have an infection preventionist trained and on staff at your facility. Well, we all know what happened right after November 28th of 2019. COVID hit in December. And so the infection preventionists were extremely busy dealing with COVID for, in fact, the last 3 years. So now it's gained more momentum, and on October 24th of 2022, CMS did release these new guidelines for surveyors to make sure that there's a trained, certified infection preventionist on staff, and then they'll start to look at all the different like tracking and reporting, things like that is expected of the infection preventionist. In addition, the infection preventionist needs to be attending the quality assurance performance improvement meetings. They need to have input into that. If they can't make it to one of those meetings, they need to send someone in their place. There just needs to be really good documentation of the infection preventionist duties now.
Yeah. Now, this happened pre-COVID, as you said. What do you know what the exact impetus was? This seems like something that would have existed before then, like having a trained infection preventionist on staff.
Yes, you would think. And a lot of facilities really do have an infection preventionist, but sometimes staffing is an issue, and that person has to get pulled to a floor to work as a nurse for that day or that shift. And so there's just more focus now being put on the infection preventionist. And we learned a lot during COVID about the role of the infection preventionist.
Sure. And can you tell me as well, Dr. Milito, what are some of the what are some of the exact requirements to be of an infection preventionist, like training, schooling, what have you?
So there is a program, an educational program from CMS. I think it has about 12 to 14 bullet points of what you'll be trained in. It's microbiology, surveillance, hand hygiene, to name a few. And you do these different modules, and then you can become certified as an infection preventionist.
Now, that was infection preventionist. That was also under F882, those requirements that you just talked about. Going back to just infection control, F880, there's some mention about multi-drug resistant organisms and proper water management. Can you talk about that as well?
Yeah, so the multi-drug resistant organisms, or MDROs, we want to make sure that facilities are reporting on any MDROs that they might have in their facility. So at probably most facilities are having monthly infection prevention and control meetings, or IPCP. And at those meetings, they should be reporting on any MRSA, methicillin-resistant Staph aureus, any Clostridioides difficile, any VRE, or vancomycin-resistant enterococci. And then another one that is rearing its ugly head is called Candida auris, and that's a multi-drug resistant fungal infection that we're actually starting to see in just about every state. It's come from South America, South Asia, and people that have traveled abroad, but they're bringing it to the United States and soon to be seen in your facility. So we want to make sure that everyone's aware of what CRS is and how to get ready for it. So not only do we want to report on that at a monthly IPCP meeting, but then that needs to go to the QAPI meetings as well, so that environmental services know, if they're using the right products to clean. Surveyors love to watch the house cleaning department people. They're going to look at their cleaning supplies. They're going to read the label. They're going to ask, do you know what this means on this label? Then they're going to watch the dwell time that the different personnel are using it. So those are some important things that you want to consider with multi-drug resistant organisms as far as cleaning. But then also, if you are getting a transfer from a long-term acute care hospital or a ventilated SNF unit, a skilled nursing facility, and they're coming to you now because it's more of a step down, you want to know if they have any multi-drug resistant organisms that have been identified at the previous location. That's very important. And then the proper water management, that's again where you get your environmental services very involved in testing the water supply, that residents are using on a daily basis, or dietaries using. But also don't forget about those decorative water ponds that may be in the entrance of a facility or inside of a facility where a resident could, dip their fingers in and, maybe, put it in their mouth. So those are some things that were pointed out in the October 24th guidelines for surveyors.
Understood. We jumped around a little bit. We were at F882, back to F880. F881, infection prevention, control, and antibiotic stewardship. Of course, anyone who's listened to our show knows that antibiotic stewardship is one of your big areas of focus. What about any particular revisions going on in that area of compliance?
Yes. So, I always like to start with the basics and pointing out that infection prevention and control is the umbrella over antimicrobial stewardship and then immunizations. Mm-hmm. And the one thing that was emphasized during the October 24th guidelines is that antimicrobials can be unnecessary as well. Now, I think that we already look at, we being the senior care consultant pharmacist, we already look at a drug regimen review and include, looking for any types of unnecessary medications. That was in CMS Mega Rule Phase 1. So there's just more of an emphasis on antimicrobials, which would be antibiotics, antifungals. Now we have, even more usage of antivirals that are being used to treat, COVID. So, oftentimes we see where an antibiotic is continuing, for 7 days, 10 days, 14 days. Where's the reassessment? And so those could, in fact, become unnecessary. Another example of an unnecessary medication is an azithromycin pack for COVID. That's definitely unnecessary because that's a virus and an antibiotic would not work.
Right. Moving on then away from that to F883, influenza pneumococcal immunizations. If I understand this correctly, this involves establishing an immunization program for influenza pneumococcal disease for residents. So just for pharmacists, and what are the important changes to heed here? So
there weren't really that many changes to that, just more of an emphasis that we have to make sure that every resident is offered those types of immunizations. So influenza pneumococcal are the two that are strongly recommended. There will be more coming with the new RSV vaccine, and then the newer COVID booster vaccine that we're not exactly sure of yet, but we think that it's going to be covering XBB 0.1.15.
Yeah. Just how many boosters are we up to now, as far as in particular for the skilled facility population? How many?
Interesting question, Adam. So someone that is not immunocompromised, they could have had 2 of a primary series, 2 boosters, and then the final booster, which is the bivalent. An immunocompromised person, they could have had up to 6 or 7 at this point. So the whole idea behind the CDC and FDA is that they had to make it more simple and to provide more harmony so that the general public isn't confused by which vaccine they should receive. So what it looks like going forward is all of the primary series goes away, the bivalent boosters go away, and you receive the new XBB variant vaccine, which will be ready in the fall.
Sounds a lot simpler. Yeah. Moving to F757, unnecessary medications, and F758, psychotropic medications. Now, we talked about this a bit in our last meeting, last episode, and psychotropic stewardship, of course. And at risk of retreading any content, if we do, that's fine. Can you take us again through what's new here in these areas?
So there are a couple things. Of note are any psychoactive medication needs to have a 14-day, any psychoactive medication written as needed needs to have a 14-day stop on it and then be reassessed to continue. If it is an antipsychotic, that is a PRN, it definitely needs the 14-day stop, but then it needs an in-person visit from the provider to continue that. And what has been a bit confusing is if it's hospice, if it's a hospice patient. So I just want to make it clear that hospice is not an exception. Even if haloperidol is being written for nausea and vomiting, PRN, for a hospice patient, it needs to have a 14-day stop. So no exceptions if it's a hospice patient. And then a second part of that is that we're looking at the diagnoses for any antipsychotic order. So what happened in the past at some facilities is a lot of residents that were started on an antipsychotic were given the diagnosis of schizophrenia. The reason that happened was that there were 3 exceptions that CMS has had for the last 10 years. They were schizophrenia, Tourette's, and Huntington's. And what they said was, if someone had one of those 3 diagnoses, then that didn't count towards the star rating of a facility. So there's something called quality measures. Mm-hmm. And there are quality measures about falls, about incontinence, and about antipsychotic use, from the short-term perspective to the long-term perspective. And what I mean by that is short-term meaning less than 100 days, like the Medicare Part A stays, or long-term would be greater than 100 days. And it's seen more in the long-term stay. So unfortunately, some facilities coded some of these prescriptions for antipsychotics incorrectly and caused a problem for everyone, to the point where there are now off-site audits taking place. This happened in January of this year, that CMS can actually ask you for a listing of all your residents on antipsychotics, and they're going to check to see if there's good documentation to deserve that schizophrenia diagnosis. So I would encourage everyone to really scrutinize any of your orders for an antipsychotic to make sure there's appropriate documentation. The MDS coordinator plays a very big role in this. And know that, for an elderly patient who's like 75, 80 years old, to all of a sudden be put on an antipsychotic for schizophrenia just is a red flag. Schizophrenia is typically diagnosed in the younger population, between 20 and 40, for example. So that would be a red flag for someone to be given that diagnosis at a later age.
Sure. So
those were a couple of the psychotropic stewardship regulations.
Moving on to behavioral health services, which is F740, I understand that there's a new emphasis on substance abuse disorders under this heading. Explain to me what that looks like.
Sure. And that's referred to as SUD. And we do have to become more familiar with that, because many of our facilities have rehab units. And what I mean by that are units that accept people after they've had a knee replacement or hip replacement, and they can't go home because there's no one to take care of them. So they need to do a short stay in your nursing home. So what if these types of residents that are coming to you have a substance use disorder and they're being treated for it, but they come to you, and so now, you need to be taking care of them, but be well aware that they have substance use disorder. And maybe they need to leave your facility to go to an AA meeting or an NA, Narcotics Anonymous meeting. They should be permitted to do that. But then maybe they come back and they're not acting themselves. They might pass out, and you might have to administer naloxone. Mm-hmm. So this is where you want to start looking at the education of your staff to be able to understand what substance use disorder is, and to know how to administer naloxone. You have to know where it is. Is it the nasal? Is it the injectable? And that would be an IM injection or intramuscular. So those are all some educational opportunities that facilities could be taking, and get your naloxone policies up to date, and any policies that are related to that.
Related to that, it's hard to talk about substance abuse or substance use disorder without mentioning opioids. And your presentation also referenced an extensive section for guidance on the use of opioids for pain management, mainly under F697 pain management. What are some of the more noteworthy pieces of guidance on opioid use in the skilled and LTC setting?
So we definitely want to look at any routine order that's being prescribed as well as the PRNs. So when we see an excessive use of a PRN opioid, we're going to look to see if that pain's really being controlled. Excessive use of PRNs sometimes means that you're chasing the pain rather than dealing with it, before it happens. So we do ask for pain assessments when we see an excessive use of PRN pain meds. We also would look for alternatives such as an NSAID, alternating with an acetaminophen order so that we can reduce the amount of adverse effects that can be seen, as we know, with opiates, with constipation, urine retention, things like that. So we are asking the nursing staff to be well aware of monitoring for the side effects of opiates and trying to prevent that from occurring, because then you have a whole nother item to deal with once you have the side effects.
The final area of your presentation that you brought up was F755 pharmacy services. This tag, of course, is pretty close to home for us. It's in our name after all. The newest info of note here that I saw involves some pretty straightforward guidance related to the disposal of fentanyl and patches. What can you tell us about this?
Yeah, so fentanyl patches, it's a transdermal system that is good for pain control. It comes in many different strengths. But this guidance has specifically said, do not dispose of a used fentanyl patch in a sharps container or a waste can in a patient or resident's room. We need to use a better disposal system, and they come in there's different containers that they can be put into. And so that's something that every facility should be looking for.
With all these areas that we've covered, Deborah, I just wanted to, while we're here, take advantage. Is there any other areas that we should be addressed right now, in addition to what you gave your presentation on? Anything that's come up in the last couple of weeks?
Yes, so July 1st in Pennsylvania, they did come out with some new guidelines, actually for just about every department in a facility. But when looking at the pharmacy services section, there are some facility-specific items that you might want to start to look at if you haven't already. I know I'll be addressing it through a medication management note, but it's something that you would discuss through your QAPI meetings, and July is a quarterly QAPI month for most people. So it's something that we'll be talking about at our consultant meeting next week, and then I'll be writing a note about that for August. But it has a lot to do with the administration of over-the-counter medications, for instance, and some labeling things. So I'll definitely be addressing those things in the near future.
Excellent. Well, Dr. Deborah Milito, I want to thank you once again for taking the time to go through all this. It's always good to have you here, and you're so knowledgeable and just go through this stuff so quickly and expertly. So again, it's great to have you on the show, and I'm sure we'll be back on again here very soon.
Thank you, Adam.
This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Catch our new episodes on Apple Podcasts, SoundCloud, Stitcher, Spotify, or wherever you listen to podcasts. Please rate the show and leave us a review. And if you have a topic you'd like to hear about on the show, or you'd like to share your thoughts on an episode, you can email us at podcastrx@diamondpharmacy.com.